Hello friends, let us now learn some. Already we have learned about different things about consolidation, and if you see the now let us learn about the patterns of consolidation. Okay, so in the patterns of consolidation, we can divide the patterns of consolidation into two types. Okay, the first type is actually there can be diffuse consolidation. Diffuse or bilateral consolidation may be seen, or you can see presence of focal consolidation. Now in this class, let us now learn about the diffuse or extensive consolidation. And first we will see the causes of this diffuse or extensive consolidation. The causes, if you see, the causes of this diffuse or extensive consolidation. Okay, first, as we have already seen, the consolidation, whenever the water enters the alveoli, that is alveolar air, whenever it is replaced by water, then this results in consolidation. So, in diffuse consolidation, first we will see water in the alveoli causing consolidation. Okay, so water or edema causing consolidation. So, in that, the first important thing is about the hydrostatic cardiogenic edema. Hydrostatic cardiogenic pulmonary edema. Here, actually, there are some volume overload. So, whatever the cause may be, first there is volume overload. Whenever there is volume overload, obviously because of increased overload of volume, increased volume, the hydrostatic pressure increases. So, this increased hydrostatic pressure. So, if you see, so we will see conditions. First, whenever there is either whenever the patient has volume overload or heart failure, obviously in heart failure also there is heart is unable to pump the blood. So as a result, the blood which is present in the peripheral vessels will remain like that only. So this is also a condition of volume overload. There can be left atrial or pulmonary venous obstruction. In left atrial or pulmonary venous obstruction, the left atrium or pulmonary vein has been blocked, and because of this blockage of left atrium and pulmonary vein, the blood, if this is the heart, this is the right atrium, this is the left atrium. Okay, whenever there is obstruction of either left atrium obstruction, this is actually right ventricle, and there is this pulmonary vein. Okay, so whenever there is blood flowing to the pulmonary vein, and here whether it is obstructed either in the pulmonary vein obstruction or whenever there is left atrial obstruction, the blood cannot pass through the left atrium into the left ventricle and it cannot be distributed. So as a result, there is increased blood in the left atrium or right ventricle. There will be back pressure. There will be again back pressure from the right atrium to the peripheral veins. And because of this back pressure, the patient will again have volume overload. Okay, or whenever the patient has decreased albumin, that is hypoalbuminemia. Whenever there is decreased albumin, there is increased transudate, like increased hydrostatic pressure or decreased osmotic pressure. That means there is number one, volume overload conditions. Number two, there are conditions with decreased oncotic pressure, like it can be due to um, hypoalbuminemia, where the albumin levels decreased. So as a result, the oncotic pressure decreases because oncotic pressure is mainly by the proteins. So albumin is the protein. Albumin is a protein. So as a result, decreased albumin will have decreased the oncotic pressure. Whenever the patient presents with liver disease, in liver disease, obviously the liver produces albumin. So because liver produces albumin, here there is decreased albumin because of liver disease, which again causes decreased oncotic pressure. Then we have renal failure. In renal failure, so you might see there are two things can occur in renal failure. In renal failure, the kidney is not able to excrete. So because the kidney is not able to excrete, so the kidney in renal failure, the kidney is not able to excrete. So obviously the blood which has to be excreted, sorry, the water or the urine which has to be excreted is present in the capillaries. So as a result, this also results in volume overload. Okay. Whenever there is volume overload or decreased oncotic pressure, so this volume overload will increase the hydrostatic pressure. Okay. Whereas these diseases like hypoalbuminemia and liver disease will increase the oncotic pressure. So now, if this is the alveoli, okay, this is one of the capillary. Okay. Now what happens is in the blood there is increased water, that is there is increased hydrostatic pressure and there is decreased oncotic pressure. Okay. Whenever there is increased hydrostatic pressure, that means there is increased amount of water in this blood vessels. So as a result, there is decreased pressure. So because of this increased pressure, the water will start flowing into the alveoli and the alveoli gets filled with water. When alveoli gets filled with water, this will result in pulmonary edema. Okay, when this pulmonary edema occurs due to cardiogenic causes like volume overload, heart failure, so then we can call it as cardiogenic pulmonary edema. Okay, so this is how we have this cardiogenic pulmonary edema, which is one of the cause for diffuse or exudative pleural effusion. Sorry, diffuse or extensive consolidation. This is first. Second cause. So first cause we are done. Okay, now second cause. Second cause is because of non-cardiogenic pulmonary edema. Okay, how does this occur? Okay, in this non-cardiogenic pulmonary edema, the main thing that occurs here is increased permeability. Why is there this increased permeability? We'll see. Okay, first, if this is the alveoli, okay, and this is the blood vessel, the end point is there is increased permeability of the alveoli so that the blood or the water from the capillaries can enter the alveoli. Why is there increased permeability? This can be seen in acute respiratory distress syndrome. Okay, in acute respiratory distress syndrome, there is alveolar damage. Okay, in this alveolar damage, now this alveoli has become damaged. That means the alveoli has some holes in it. So as a result, the blood from the water or the transudate from the capillaries might enter into the alveoli through the damaged part very easily, resulting in pulmonary edema. Okay. Now, what are the conditions which can result in ARDS? ARDS is seen in acute interstitial pneumonia, where the interstitium is the area between the alveoli. Between the alveoli, we have some connective tissue area which is present, which is called as interstitium. So whenever there is infection in this area, this can result in acute respiratory distress syndrome. If the patient aspirates any fluid, aspiration of gastric acid, so now this gastric acid will reach the alveoli and obviously it causes alveolar damage. If the patient ingests some drugs or if the patient has any fat embolism or if the patient has any infection or conditions like sepsis. Okay, if the patient has undergone any radiation which can damage the alveolar cells like nematocytes, type 1 and type 2 nematocytes, or shock, or if the patient has any inhaled any toxic gases, or if the patient has any trauma. In all these conditions, the patient will have some damage to the alveoli, and it results in results in acute respiratory distress syndrome, leading to pulmonary edema. Sometimes, whenever there is drug reactions, or whenever there is a transfusion reaction, drug reaction or transfusion reaction, or if the patient has any hantavirus pulmonary syndrome, or in presence of hantavirus pulmonary syndrome, okay, in drug reaction, transfusion reactions, hantavirus pulmonary syndrome, here there is no alveolar damage. There is no diffuse alveolar damage, and as a result, but this also will lead to pulmonary edema. So this means the pulmonary edema can have two ways to occur. One, it is by alveolar damage. Second, without alveolar damage. Okay. Then, so these are two different types of edema. And we have other types of edema also. The third one is other types of edema where the alveoli is replaced by water. Okay. These include when the patient has air embolism, okay, or high altitude pulmonary edema, where pulmonary edema occurs in patients living in high altitudes, or we have neurogenic pulmonary edema. Then we have after transplantation, if the patient develops pulmonary edema, then we call it as post transplantation pulmonary edema. Or if the pulmonary edema occurs after pneumonectomy, after removing the lung, if the pulmonary edema occurs, then it is called as post pneumonectomy. Oh, sorry. After pneumonectomy also. How will pulmonary edema occur after pneumonectomy? That is wrong, right? So even after pneumonectomy also, the lungs, the alveoli are filled with water. But how is something which is weird? If you guys know the answer, please comment in the comment section so that I can update in this video. Then we have re-expansion edema. Conditions like re-expansion edema, we have reperfusion edema can occur, okay, or so all these are different types of edema which can also replace the alveolar air with water, resulting in consolidation. Then is it just water? No, alveoli can also be replaced by blood. So what happens if alveoli is replaced by blood? Obviously, if alveolar air is replaced by blood, so that means if this is the alveoli which is filled with air, now this alveoli, if this is replaced by blood, then always remember one thing: if this alveoli is actually replaced by blood, then this is seen as consolidation only. Okay. Now, what are the conditions where you can see this alveolar replacement by blood? Whenever the patient aspirates the blood, then through the bronchi, the blood reaches the alveoli, and you can see the alveoli filled with blood. It can be due to some bleeding diastasis, where the patient has some coagulative factor deficiency, or some issues with anticoagulation, okay, or if the patient is on chemotherapy which kills the coagulative factors, or if the patient has low platelets, because platelets is very important for coagulation. So if the patient has low platelets, or if the patient has any leukemias, okay, in all these conditions you can see that the alveoli are replaced by blood, resulting in consolidation. So in anticoagulation, chemotherapy, low platelets, and leukemia. In all these conditions, the alveolar air which is present, actually all these are conditions where bleeding is more common. This, in all these conditions, the patient has increased risk of bleeding. So because the patient has increased risk of bleeding and the coagulation is not proper, so the patient continues to bleed. So continuously the alveolar air will get replaced by blood, resulting in consolidation in these conditions. Similarly, hemorrhage in alveoli can also be seen in some connective tissue disorders, or we can also call it as in some collagen vascular diseases or connective tissue diseases, like in SLE, systemic lupus erythematosus, or in Behçet's syndrome, or in conditions like antiphospholipid antibody syndrome, or in conditions like Henox-Conlin purpura. Okay, in all these conditions, one important thing is that you can see pulmonary hemorrhage. Okay, in all these, because of here there is defect in collagen, and if you see, collagen is important for healing. So whenever the bleeding starts in the alveoli due to any reason, if bleeding starts in alveoli, it is very difficult for the bleeding to stop because of defect in collagen. So as a result, here in all these conditions, we see presence of pulmonary hemorrhage, and thus we see the uh, blood in the alveoli resulting in consolidation. Then even some more connective tissue disorders, like we have Wood-Pascore's syndrome. Okay, we also have certain vasculitis also. These vasculitis will also come under connective tissue disorders only. These vasculitis includes, we have Wegener's granulomatosis. Okay, then we have Church-Strauss syndrome. Okay, then we have Church-Strauss granulomatosis. Then we have microscopic polyangiitis. So all these are actually the conditions where you can see the presence of blood in the alveoli, that is pulmonary hemorrhage is common in these conditions also. Okay, trauma can also lead to pulmonary hemorrhage, causing blood in the alveoli. Okay. We are done with blood in the alveoli, and we are done with water in the alveoli. The third important thing is alveoli can also get filled from air. It is replaced with pus. Alveoli might be replaced with pus also. Okay. Now, if alveoli is replaced by pus, it is seen in bacterial pneumonia. In bacterial pneumonia, the alveoli which is filled with air is now replaced by pus. Then in pneumonia in immunocompromised. In patients with immunocompromised patients, okay, pneumonia in immunocompromised patients also, obviously in pneumonia the air is replaced by pus. In tuberculosis or in any non-tubercular mycobacterial infection also, you can see that the air is replaced by pus. Or in fungal pneumonia, like especially in fungal pneumonia, we have diseases like histoplasmosis, or we also have, which is caused by histoplasma, and we also have aspergillosis. In all these conditions also, we will see that the air is replaced by pus. Then we have certain atypical organisms which can cause consolidation, like even viruses and pneumocystis can also fill the alveoli, replace the alveolar air, and it can cause the this consolidation. Then sometimes there can be cells which can replace the alveolar air. Alveolar air can be replaced by cells also sometimes. So if alveolar air is replaced by cells, it is seen in neoplasms, like if the patient presents with pulmonary adenocarcinoma, if the patient presents with pulmonary adenocarcinoma, or if the patient presents with lymphoma and other lymphoproliferative disorders, if the patient presents with eosinophilic pneumonia, or if the patient presents with organizing pneumonia, then if the patient presents with some sarcoidosis or idiopathic interstitial pneumonia, in all these conditions, the air is replaced by cells. Idiopathic interstitial pneumonia, like we have non-specific interstitial pneumonia, or we also have desquamative interstitial pneumonia. So in all these conditions, the the alveoli is filled with cells. Okay, sometimes the alveoli can also be filled with lipid. If the alveoli is filled with lipid, then we call it as lipoid pneumonia. Similarly, if the alveoli is filled with proteins, if the alveoli is filled with proteins, then we can also call it as alveolar proteinosis. So these are the different causes of diffuse pneumonia. Diffuse consolidation. Instead of diffuse pneumonia, we can say these are the causes of diffuse consolidation. Thank you.